Thank you. I'm David Berry from the Scottish Government Dementia Policy Team. I'll keep this quite brief because I know it's getting near the end of the day. So I'm just going to give a very quick overview into the policy context in Scotland since 2007. The only two things I'll pick out of this slide are the first point about the number of people we think are currently in Scotland with dementia, around about 86,000. You may have heard the 90,000 figure earlier on. That's based upon the same prevalence model, which is a European model that we use. So we have broadly a common assumption about the scale of the challenge across Europe. We probably think that needs to be revised down slightly. In England, they've adopted a slightly different model this year, which, if applied to Scotland, would take us to about 60,000. That's not to say it isn't one of our biggest public health challenges, but we think there's probably more people developing dementia much later on and living for much shorter periods of time than we previously thought. So that's why prevalence may be lower, but incidence may be higher. The other thing I mentioned here is the estimated spend on dementia in Scotland per year. We often get asked how much we spend on dementia services. The answer is we don't know because it's drawn from our overall allocations to health boards and local authorities. That's the estimate. If we factored in the spend on unpaid care from families, you would double that at least, but it's impossible to actually get an accurate figure. This is just a potted history of the first 6 years in dementia policy. Since the SNP made dementia a national priority in 2007, what I'll pick out of that is the work around diagnosis. The first thing the Scottish Government decided to do was get a better idea of diagnosis rates in Scotland and to mainly focus on improving diagnosis rates. So you can see there a diagnosis target which started in 2008. The result of that was that diagnosis rates in Scotland increased by about 25% in 4 years. That rate stayed pretty much stable since then. Scotland's diagnosis rate is about 10% higher than England's at the moment, which is quite a big difference, but it's 25% higher than Wales, which is a huge difference. So we're much better at diagnosing dementia in Scotland. Northern Ireland's rates are almost exactly on a par with ours. Internationally, it compares quite well as well. We're either diagnosing half of the people with dementia in Scotland or 3/4 of the people, depending on which prevalence model you use. Either way, we're doing quite well, but we obviously need to improve further. These are the challenges that were laid out in the current strategy, which comes to an end next year. The first two are really about the quality of life for people with dementia. So we've moved away from what might have been a traditional medical model for dementia to broaden it out beyond medicines, because obviously there's limited scope for medical interventions at the moment. We can slow some of the symptoms of dementia, but we've really tried to broaden out the understanding of dementia service to make it a holistic, person-centred model, where the main intervention is skilled human intervention. At the current phase we are in terms of understanding how we deal with dementia, that has to be our approach to dementia. The third bullet point there is really around redesign. A lot of what we do in government is around supporting service redesign, so it's around gathering data on performance across Scotland in various parts of the dementia system and then feeding that back into the system in terms of the people who commission services, to try and convince them of the need to commission particular types of services in their local area. So that's an increasingly big part of what we do in Scotland is harvesting data around dementia. We've got 17 commitments in the current dementia strategy. I've talked about diagnosis. I'm just quickly going to mention 4 more of them. Probably the most distinctive part of dementia policy in Scotland is post-diagnostic support. Elsewhere, there tends to be a big gap between diagnosis and then crisis interventions. We've tried to kind of shift the paradigm so that we've tried to circumvent the issues we have in Scotland around things like eligibility criteria, so that people can get help much earlier, so that if you get newly diagnosed, you're entitled to get a link worker and to get a minimum of a year's worth of support. The benefits of that are to give people time and space to understand the illness. So it turns the kind of targets culture on its head, whereby traditionally it's about access, how quickly you get access to a service. This is about getting access quickly, but also getting service over a long period of time. which is a minimum of a year. The idea at the end of that period is that you have a person-centred plan which will then travel with you throughout the dementia journey. One example of the benefits of getting a post-diagnostic service is that the family and the person with dementia can work as early as possible to plan for future care options. So things like getting things like welfare guardianship sorted out, financial guardianship, and the person with dementia having a real say on what happens to them later on when they're actually not able to make decisions for themselves. A big part of what we're currently doing is we're working with 5 areas of Scotland: Glasgow City, North Lanarkshire, Midlothian, Moray and Highland, to test an Alzheimer's Scotland service model around the phase of the illness that probably affects the most people at the moment in terms of the impact, which is when they're still trying to live at home, stay well at home, but when the symptoms of dementia are actually impacting on them directly, and they need a very intensive intervention over an extended period to stay well at home for as long as possible to try and avoid unnecessary hospital admissions. People will get admitted to hospital with falls or burns, but it's to try and minimise that because of the deterioration that happens to people when they go into hospital. Often they won't go back home afterwards. Also to ensure people don't go into residential care unless they absolutely have to. More and more residential care in the future will be about palliative end-of-life specialist dementia care. We're trying to avoid more people going into residential care till they absolutely have to do that. Of course, a big part of that is making sure that carers are supported as well at home, and a big part of what we're testing is a very proactive approach to carers' well-being as well. We're currently we've just started evaluating that project, and that will report next year. Part of the spine of dementia policy is providing a big chunk of investment every year to train the dementia workforce. So that's over and above the money I mentioned earlier, with the $2 billion which is spent on dementia services. We provide additional funding to enable services across Scotland in health, social care and housing to deliver the standards of care for dementia that were mentioned earlier. That involves undergraduate education, pre-registration training, and continuing professional development for all parts of the dementia workforce. So we have a national approach to doing that, which is delivered by NHS Education Scotland and the Scottish Social Services Council. I've just put at the end there an example of 300 dementia ambassadors currently trained in Scotland within the social care sector through that programme, which includes 70% in residential care, and their frontline staff who take on additional responsibilities to change dementia care in their care settings. Another big part of what we're doing is improving care in hospitals. So I said earlier that we do try and prevent people going into hospital, but when they do have to go to hospital, people with dementia need a particular type of approach, and part of that is recognising they do have dementia and recognising that they need to have discharge planning made as soon as possible to enable them to get back home if that's where they've come from. People in general hospital traditionally have gone in there not thinking they'd be working with people with dementia, but in fact it's a massive part of their client group they'll deal with, and it's really a case of beginning to work with people in general hospital to make them aware of that a bit more and to support them in doing that. We've got 500 dementia champions in general hospitals, and we'll have another 100 graduating soon. So we're just about to start consulting on the third 3-year strategy. So we tend to have really short strategies so that we can adjust what we're doing really quickly, so we don't have 10-year strategies. We try and change things, and if our understanding of the dementia challenge changes, we can adapt what we're doing really quickly, which is probably what we're going to start doing in the next 3 years. Part of that will be an increased focus on palliative and end-of-life care, because I think we know now there's many more people dying every year with dementia than we previously thought. So we need to have a much more strategic approach to palliative and end-of-life care. The events that I mentioned there, I think they're pretty much booked out, although we have announced a national event last week. And if anyone's interested in that, they can let me know. And we can send information out to people through this contact list about that event, which is on the 3rd of December in Edinburgh. As well as workforce, another big part of the next 3 years will be the integration of health and social care. which is probably the biggest part of public sector reform in Scotland. The dementia client group is a massive group that will benefit from that if that can be delivered effectively. And in the middle there, improvement support. Eileen mentioned focus on dementia. That's going to be a part of a big national programme of improvement support to help services make the changes they need to change dementia services. Obviously, technology-enabled care is going to be a big part of the story in the next 3 years, but even more so in the future. I think so. That's going to be a big thing for everybody. In the middle there, primary care. We're going to begin to test new approaches to diagnosis within primary care as well as part of the next 3 years. But really, the purpose of what we're starting next month is that we can listen to everybody who has an interest in dementia from whichever perspective they have to inform the next 3 years. Okay.
Fantastic.
Thank you.
Thanks, David.